Should upfront CAR T-cell therapy be part of the early treatment for relapse refractory multiple myeloma? And I was part of a debate. I was subbing for Dr. Moreau, who couldn't make it to the meeting. And I debated Dr. Yakobaga, who had the pro position, and we sort of met in the middle because the use of, right now, BCMA CAR T-cell therapy, which is the most widely used type of treatment, is still not commercially available. It's still on protocol. And we're still not certain how to use it. Myeloma is definitely not like ALL, where there's a pretty durable long-term disease control and probably cure, even for some patients who don't go on to an allogeneic transplant. For myeloma, there's still relapses. MRD negativity, which means a lot after an auto transplant, may mean less after a CAR T-cell therapy, as there are still patients who become MRD negative yet still have progressive disease relatively early. The median progression-free survival for the Bluebird study presented by Nupa Raji in the New England Journal was about a year. But these were also heavily pretreated patients. So there's some data from the Penn group that perhaps if you collect the cells early, you'll have a more robust product to manufacture the CAR T-cell product. We don't know that yet, but it remains to be determined. And then we have to determine, are we going to manufacture on all patients, high risk? How are we going to utilize this? We're not sure. It's a great problem to have in that we're targeting BCMA with cells. We're also having it targeted by an antibody-drug conjugate. GSK has a drug antibody conjugate, which may be a very effective treatment and be commercially available next year. There is a BCMA BiTE, which is a BCMA with a bispecific T-cell engager. That's being made by Amgen, and that was presented at ASCO. They reformulated it. They're testing it again, and that may be something that'll be utilized. What we also don't know is if you get a BCMA BiTE or a BCMA drug antibody conjugate, how will that affect a BCMA CAR T-cell? We don't know. We don't know how to position all of these agents, and this is a good problem to have. Never mind all the other drugs we have available. Selinexor was approved this year for relapse refractory disease. Most of the CAR T-cell studies, especially in the US, mandate daratumumab exposure. So we are seeing a much more heavily treated patient population going on to CAR T-cells. And how we position that to move it up front remains to be determined.